Our next presenter is joining us virtually, so we just want to make sure that we have some video and audio running through. Stephen, if you could just wait one more minute, we're just doing a final double check. Thanks so much.
Hi, Steven. Good to see you. Thank you for being here.
Of course. Thank you for allowing me to present. I'm right outside, actually, our NICU right now, too, because I was unfortunately on service this weekend, so couldn't make it up to Boston.
Well, thank you for taking time. It's my pleasure, everyone, to introduce you to Stephen Lazar. Dr. Stephen Lazar is a associate professor of pediatrics and fetal, neonatal, and child neurology and neurodevelopmental disabilities, and the medical director of the NICU follow-up program and the Neuro NICU at Texas Children's Hospital through Baylor College of Medicine. We have talked to Dr. Lazar and Stephen many times with some different things about neurocognitive development. And this is such a big topic that a lot of our families are always asking questions about long-term outcomes, executive functioning, a lot of the things that kind of pop up later in childhood for many of our kids. And so I'm really grateful that you're able to join us virtually. I wish you were in the room, but we'll catch up with you, I know, another time. And I look forward to hearing the presentation and us having a conversation afterwards with you. Thank you so much for joining us. And here we go.
Of course. Thank you all so much for inviting me. And thank you so much for that introduction, Betsy. And I wanted to be able to speak to you all today. I know you're asked to talk a little bit about neurocognitive outcomes and kind of these big picture things about, well, what after the NICU and that experience. And I'm going to do my best to probably not end up answering a lot of specific questions because what I want to do is walk you all through a little bit for kind of how I envision and see individualized follow-up out of the NICU, especially in the context of HIE. So we can go next slide. And what I'd like for you all throughout the course of this talk to be able to recognize kind of what neonates and infants have the highest potential for any number of neurodevelopmental disabilities, challenges as they move forward in life, to be able to differentiate between different approaches to NICU follow-up, because as many of you probably seen in conversations amongst each other and what with your connections and community, there isn't a one size fits all. And many programs are built completely different, where there isn't one kind of even gold standard for kind of what follow-up should look like. And there's major differences between research-based follow-up programs and clinically patient-focused programs. And so excuse me. And lastly, I want you all to be able to think, and I know you had a session this morning really talking about what are the, excuse me, need some water. What are the most important things for families and those with lived experience when physicians and other professionals talk about outcomes and helping to talk a little bit about what the future could look like. And I'm in complete agreement with Hope for HIE that what often historically researchers and physicians have said is a quote unquote good versus quote unquote poor outcome does not align with what families' experiences actually mean for those terms. So we'll walk a little bit through that as well. Next slide. So one big disclaimer is that I'm not going to be going through actual numbers and percentages of this percent of patients with this pattern of HIE will have this outcome, because those numbers in my mind are helpful for some families. But at the end of the day, even if it's 1%, if you are in that 1%, it's 100% of your life. So what I want to walk through is a little bit more of a broad general approach to how we can clinically look at follow-up systems over time and why that follow-up looks differently over time. Next slide. And please make sure to ask questions. I know that the Q&A will be monitored and we'll also have a few bits of interactivity. Next slide. Perfect. And so now let's get to the meat of the talk. What are these big questions about neurodevelopmental and neurocognitive follow-up? Well, one is why? Why is it necessary? Who should be getting this? When should they have their visits and at which time points? How does these visit actually occur? And what is the outcome of these clinics? Kind of what is the package for families at the end of the day at the visits? Next slide. So, why is it important? Well, this one very clearly, as I think you all have experienced too. Well, one, we want to be able to help the patient. So, the person in front of us who has been affected. And that is to apply kind of individualized developmental assessments, understanding all of the different medical components that families face as they move forward in life, and also helping provide anticipatory or guidance as they move forward for things to be on the lookout for, to be proactive, to help all people in front of us achieve their highest potential. And we also want to help the family. We know that it is a family unit. In my mind, as a neurodevelopmental specialist, I treat the entire family unit within their context, as opposed to only thinking of just the person in front of me, and especially even more so than just the images or any lab tests. And lastly, we also want to be able to help the NICU, meaning that we want to be able to understand what happens after people leave the ICU and to be able to provide that feedback to understand a little bit more to improve the care that families have experienced and get. Next slide. So now we're going to be using our Menti a little bit just to get an understanding for those that are here. If you don't mind joining this, the first talk's going to be a little bit, or the first question is going to be a little bit about what experience have you all had in a follow-up system after the NICU?
We'll just give it a minute for everyone to get connected in the room. I know we're all pros at this now, so hopefully no issues. Oh, no.
So this first question is that what type of follow-up was offered for your child after the NICU? And this is kind of three relatively vague descriptions, but first kind of saying that there's a comprehensive follow-up program directly from the NICU. The second option is that you were referred from your primary care into a specialty evaluation, or no specific comprehensive follow-up was recommended immediately after leaving.
It was kind of this, but it wasn't good.
Perfect. And I think as we can see that there's definitely some variability where the majority were referred directly into a developmental follow-up program specifically for their follow-up of HIE and potential developmental consequences, but about a quarter were not directly offered a comprehensive developmental follow-up. And there's many different things that can come forward to that. One can be, did you quote unquote qualify for that follow-up based on an MRI? Is where your child was born or where you live impacted whether or not it was even available for you? So there's definitely a lot of variability out there for what is offered and what's available. Right? And the next, for those that have had the opportunity to have one of these developmental or neurodevelopmental evaluations, If you think back, what do you feel was most important for you at the time of that visit? Or even looking back, what you now realize you wish you would have asked or thought would have been more important than was covered. Proactive ways to support development, thinking about next steps. Haven't had one yet. Yep. Which ones need intervention or which problems might? Understanding what could be support to know what is normal or not. So really, yeah, that counts in on kind of what is typical development versus what is related to the prior history. Yeah, which therapies specifically, being able to share progress across different specialties. hmm Yeah, and then also kind of, well, where do we go from now? Once there's an age cutoff for, okay, the clinic falls to XYZ, then you're on your own. Understanding what the future might hold, next steps. So this really, I think, gives a lot of good clarity to something that I always do in a neurodevelopmental approach. What we find is that a lot of times I recommend when I'm teaching trainees medically, learning how to do some of these evaluations, thinking about all of these things, is that we want to be able to answer four major questions. The first question is what's going on with my child? So kind of understanding a little bit of what is the what we call clinical diagnosis. Is there a delay in development? Is there a specific learning disability that we can describe and see in front of us? The second is why. Why does my child have this diagnosis? The third is, well, what can we do to help? The intervention plan. And fourth is, what does all of this mean? What does the future look like? And those are four kind of major questions that have consistently come up in my experience and with speaking with families like yourselves. Next slide. And so that kind of ties us back into kind of this idea, well, what are some general approaches that NICU follow-ups have been built? And this has kind of been categorized into two major areas. One, which a majority of you had mentioned that you've been through, is that you're directly referred into developmental assessments and surveillance by follow-up specialists directly into one of those clinics right out of the NICU. But what we know too is that model two, this idea that you don't directly go into the clinics, but you start with your primary care, or there's a screening process where you have to meet certain qualifications to actually get into these programs afterwards. And what we know is large data is that the majority of families who get NICU follow-up broadly, encompassing all components of NICU, are actually in that model too, meaning that they are getting their care through their primary care. And then they're being referred to centers if concerns arise. Or the very last one, they skip this whole kind of clinical center and they get just referred directly to therapeutic interventions within the community. Next slide. So then we're going to take a big step back and look a little bit more of how. So what I want to share a little bit is my approach and this neurodevelopmental approach to child development and kind of thinking about developmental disability and where that fits in for these different diagnoses when they come and why children tend to be seen at different times. And so it's important to understand how we view kind of the general principles of child development. Well, number one, we know that child development typically follows a predictable, orderly sequence in which more basic skills are achieved before higher level skills. This is the idea that you start with head control, then trunk control, then extremity or arm and leg control, such as rolling to sitting to standing to walking, similar language, kind of when we think of typical developmental milestones, they follow in a relatively orderly sequence that are expected. And it's usual that all areas of development progress at about the same rate. So meaning you do the average 12-month skills in your gross motor or big muscle skills, the walking, sitting, as you do with language. You're doing things at about the same pace in all these different areas of problem solving. Next slide. And when we break this down, I use this term streams of development. Well, this is because we know that child development isn't just a single number or a single concept. There are many different parts of brain development. And this has been kind of distilled down into a few categories so that we can start to fine tune things. Because I know some pretty consistent questions that come up is that, well, what about executive function? What about fine motor function? What about all these different areas of problem solving development? Because we know that they are related, but there are separate skills. And so we think of motor development, which includes your big muscle skills, your hand use, fine motor skills, oral motor skills, things like eating, drinking, but also the way you move your mouth, tongue, throat to make sounds, the actual movement component. And then there's this concept of central processing, this idea that this is that problem solving skills that develop your language abilities, your understanding of what is said or shown if you're signing, and vision problem solving skills. So this idea of visual perception. So kind of you see something, you can incorporate hand-eye coordination and solve problems with it. And you need both of these levels of problem solving skills to varying degrees to express social skills and your adaptive and self-help skills. You need to be able to ask for help. And so all of those things integrate into that social and adaptive. And lastly, there's also this idea of neurobehavior. So this is really where mood and activity levels, attention, temperament, and kind of general kind of personality type traits that we try to describe for children as we see it. And all of these seem like separate categories, but we know that nothing occurs in a pure silo. Next line, please. So when we take that idea of typical expected child development, well, how do we then approach it when that's not what we're seeing on an assessment, meaning something's a little bit different? Well, we know that a key principle when we're thinking of developmental disability is that there's a spectrum of disability within each of these areas. And so this is the idea that more mild disability is much more common than severe disability. One example we sometimes use is that, well, somebody who has specific learning disability or dyslexia, a specific reading challenge, there's a lot more individuals who have that than there are that with severe or profound intellectual disability or what used to be called mental retardation. It's just this idea that mild disability is more common than severe disability from a population level. And second, the more severe the disability tends to be, or the more impacting of everyday life it is, the earlier it can be identified. So I often say that I can't diagnose dyslexia, to use that continued example, in any 12 or 24-month-old. They need to be at the age in which we can approach reading attempts and things too at an older age. But we can make a presumed diagnosis of, we know, cerebral palsy in certain cases and things too, even in infancy, especially when there's more impacted function expected. So we know that the earlier a definitive lifelong disability diagnosis is made, the more impactful of everyday life it is expected to be. Next slide. But then we also know that not only within each of these areas is there disability, we know that there's a continuum across these different areas of development. So what we often say is that the biggest thing that is most noticeable is often just the tip of the iceberg. So when a family comes and says, hey, I'm concerned because my child is not talking, or I'm concerned that my child is not walking, it's very important for the developmental specialist to think broadly and look at a comprehensive, holistic view of the child, because often just that one specific thing may just be the start of looking at all these different patterns of strengths and needs. And so it's actually a little more common that multiple areas of development are affected when you find one. So it's more that these co-occurring diagnoses are the rule rather than the exception. For example, children with dyslexia are about 5 to 8 times more likely to also have a diagnosis of ADHD. And the inverse is also true. So we always need to think broadly and not hinge on one specific descriptive diagnosis. And we'll get into what I mean by that a little bit later. Next slide. So the last key piece is that when we see developmental assessment, so kind of when did your child do this skill? What are they doing right now? What are you working on? And understanding these differences from typical development, that all is a reflection of difference in the way the brain's developing and that processing of information. So, of course, I say this because I'm biased as a neurologist, but all development comes from the brain. Communication comes from the brain. And we want to be able to understand that, hey, the more their development is impacted from whatever reason, the more we need to understand and contextualize the behaviors that we're seeing. So this is how we try to understand more complicated diagnoses as kids get older. Next slide. So what do I mean by these terms? Well, we know that when we're thinking of child development, that we can describe differences in development. They can be delayed, meaning that a child is achieving milestone skills and progressing their development, but it's a slower speed than expected. And there's descriptions of what's called dissociation, meaning that the speed of development is different across these areas, meaning that they might be doing all of the movement related skills, walking and running and doing those skills, but their language and communication ability seems to be lagging. This is how we can describe a difference between areas of development. There's this concept of deviation or disorder, meaning that, hey, they're achieving skills out of the expected order. So this is kind of, well, pulling to stand and rolling before they have full head control. Sometimes the early acquiring of milestones before you've mastered the basics can be a sign of the brain developing in a different and unexpected way. And then we also think about regression. So meaning that they've developed and mastered certain skills that they've used consistently for a few months and across multiple environments, and then they lose the ability to do those skills. And those are all descriptions for what we see with talking with families and doing some of the assessments we do. And we can quantify development with a number. So we often use what's called a developmental quotient, meaning that, okay, the child in front of us is performing based on history and what we observe doing the testing at a X month level average. And we can divide that by their age. And then we can kind of get a sense of a speed or a velocity of development. And next slide. And we then can apply that to this idea of that, well, not everybody needs to do things at the same exact level. There is a lot of variation in normal child development too. So what is that threshold for when somebody's delayed? What is the threshold to say that there's a significant difference between these areas? Well, we apply and use kind of what's called that normal distribution. I use this IQ as an example. But what we see is that we know the majority of people in the population will be around the average. And the further you get away from the average, the fewer and fewer people there are in that range. So in using IQ as an example, we know that if a child is developing at a less than 70 to 75% of the age average expectation, that's what we formally diagnose as a developmental delay. And that is just a description of a speed of development at a point in time. Over time, that delay may transition into a disability-based diagnosis. And the earlier that delay to disability transition happens, the more significant the impact on everyday life is expected to be. And that ties back into a little bit more of our earlier discussion on how the more impactful it is, the earlier diagnoses can be made. Next slide. So, okay, now that we've talked a little bit about kind of, okay, let's take this big picture. This is what typical child development looks like. This is how we can start to think about when that expectation is not quite there. And we know that there's a whole lot that goes into child development aside from those internal factors. We know that there's biologic risk factors, including things that happen during the pregnancy, intrauterine, birth, diet, nutrition, infections, and overall general health and other medical issues. We also know that there's the environment around it too. This is the idea of parental health, parental education, caregiving behaviors, home environment. This is kind of that bundle of support and thinking through what are some other challenges or stresses that may be on in impacting the child's development. How can we really help support across all these areas? Next slide. So this gets us to a relatively complicated but foundational concept in neurodevelopment. And what I'd like to walk you all through a little bit is that when I approach anyone for a developmental consultation, I think about three, for lack of a better word, levels of diagnoses or three types of diagnoses. We know that there can be individual daily impairments, kind of what is challenging on an everyday basis, or what are the exact scores we see. So you can see in this graph that there's a broad array of impairments. There's cognitive or thinking skill issues, including executive function, memory, academic skills, IQ. There's motor difficulties, so your posture, movements, muscle tone, strength, reflexes, that neurologic exam, behavioral difficulties, attention issues, activity issues, mood regulation issues, and also differences in brain development and things like seizures as an individual symptom or abnormal EEG. And when we approach the child, we can take these individual impairments and put them together to understand the child to make a clinical diagnosis. So, for example, somebody who has a below average or below certain standard deviation IQ or performance measure, and they have daily functional difficulties in both their language problem solving and their non-language problem solving, we can put that information together to give a descriptive diagnosis or a label of intellectual disability. If there's disordered or challenges with posture, movements, muscle tone, either stiffness, tightness, increased reflexes in the right setting, we can put that information together to give a clinical diagnosis of cerebral palsy. The same thing happens with epilepsy. You can have seizures and you can also have abnormal EEG. And based on certain criteria, having more than one seizure that wasn't caused by any provoking factor, like a low blood sugar, HIE, in the setting of when that current injury happens, we can make a clinical diagnosis of epilepsy. Now, none of those diagnoses tell us specifically why someone has intellectual disability, why someone has cerebral palsy, why someone has epilepsy, because that big why question is more into what we call the etiology. And that's how we need to take a step back to think about this and say, well, we know that there's a whole lot that can impact the developing brain. There's genetic factors, there's metabolic, the way the body processes energy, infection, immunologic, inflammation, hypoxic ischemic, and trauma. All of those things can change the way the brain's been developing. And it's a bit of a black box because we know that even with the same MRI or the same exact genetic change, there is a broad array of what impairments that person may have on an everyday basis. So not everyone with HIE has the same outcomes or clinical diagnoses. But putting these pieces together, they're different ways. And so we often describe in multi-stages. So kind of saying that, hey, they have these specific challenges, which we're describing together as this diagnosis that is due to the etiology or cause. Next slide. So why does this matter? So this is a little bit more of an example that we know that etiology or the cause. We can think of things like trisomy 18, Fragile X syndrome, different genetic disorders, or HIE, things like that too. We know that there's a broad array of diagnoses that families may face: intellectual disability, specific learning disorders, language disorders, cerebral palsy, ADHD, autism, epilepsy. But all of those diagnoses are made based on the person in front of us, not directly related or made because of the causing diagnosis or the etiology. Next slide. So, why did these matter then at the end for that big third question? What can we do to help? Well, actually, it's not at the end of the day when we're looking at developmental diagnoses so much why that helps us with giving treatment recommendations. It's more what the day-to-day impairment is. Just because you have a diagnosis of HIE doesn't mean that there is a perfect combination of therapies, interventions later in life, because it will be dependent on the person's daily function and how we can help support them at an individual level that affects them on an everyday basis. It can help a little bit understanding, well, this individual has a diagnosis of intellectual disability, ADHD. That can give a little bit of guidance for medicines and some different plans, but the type of support someone needs in school isn't necessarily due to the why, it's where they struggle, and to help create that individual curriculum plan. And so we can see that thinking about someone at this broad array of the daily impairments, what kind of descriptive diagnoses there are, and the underlying reason for why can all help give guidance for all these different areas. Next slide. And then it goes into, well, okay, that was just a whole lot, all these different labels, all these different diagnoses and all those things too, but kind of like, well, when should we know about this? When should we be able to assess different areas of development, thinking skills, and all of those things too? And well, the reason why in NICU follow-up programs, we need to be able to follow children over time is because the brain is constantly developing. The brain actually starts to develop way early in the first trimester. It starts with that initial folding of the brain, and then the neurons start to become more and more and more and grow. And then they actually move from the inner part of the brain to the outer part of the brain, and then all the folds start to develop. That all happens in pregnancy. Then a pattern of continued brain development typically occurs, which is where the fatty fibers that help make connections and build different experiences and memories and how all these neurons connect and create new networks develops over years. And so what we know is that different parts of the brain mature at different speeds and at different times. Next slide. So this gives us this concept of early intervention because we know that there's a certain period early in life when the majority of these brain changes happen. While the brain changes are still happening over time, the majority of them in that new network building is in the first few years of life. And babies start predominantly as reactions and responding to their environment around them. Then over time, as their brain matures, they start to do their own control of their movements for purposeful movements and some of these other things too, where they're initiating these things as opposed to just a reactive response. That's a part of typical development. And we want to be able to ensure the highest amount of intervention early on. Next slide. And we assess things differently because what we know is that vision development, we can assess a lot of those big changes based on the vision pathways maturing over the first year of life. And then we know cognitive development and executive function development, that really doesn't even start because those parts of the brain don't start to take over the majority of the work until they're older or a couple years old. And so we know that we focus on different things at different times in follow-up. Next slide. So when should we actually stop to see them? When should we put these time frames? Well, in an ideal world, these are some of the general key, what I like to call watershed components, meaning that, hey, these are going to be the best bang for your buck timeline for visits. So early in life, we tend to see kids every 3 to 6 months during the first year of life because that's when the most rapid amount of brain changes happen. And that's where you can start to pick up severe to significant motor impairments and cognitive impairments and challenges. Then 18 to 24 months is another big area where you can start to see more mild movement related disorders. You can really start to understand language based impairments at that point. And that's also if your child was born premature or things too. That's when you generally stop giving that correction for prematurity. And then again, at 30 to 36 months, this is where you're going to pick up the majority of significant behavioral issues. So sometimes signs of early, significantly impairing attention dysregulation, ADHD, autism, and those behavioral social components, because there's not much social you can really give expectations for somebody under 12 months old, but there's more and more expectations at different ages. So you can really start to pick up more and more subtle things that may not have even been able to be recognized earlier in life. And 30 to 36 month into that 3 year stage is where we start talking about pre-K or pre-kindergarten, preschool readiness. And it's also when early intervention programs in the United States end and they start transitioning into school-based services once somebody turns 3. Then at 5 years is for kindergarten readiness, where you can start to see early academics, more mild language impairments, even more mild social impairments. Then again at 7 to 8. And this is kind of that second to third grade transition. This is where you can really start to pick up more mild learning disabilities. And when I use the term mild, it can still be very impairing on an everyday basis. I'm using that terminology a little bit compared to more significant daily impairments as opposed to more isolated. So things like just reading disorder or math-based learning disorders, because second to third grade is when they stop focusing all their time teaching kids how to read, but also when you need to use reading to learn all your other subjects. So you can start to see changes in academic performance around this age, and formalized IQ testing and other cognitive testing have pretty good consistency at this age. And if you were to retest them when they're adults. So that's when a lot of these scales and scores tend to be stable when you're testing them again over time. Next slide. So what does a visit look like? Well, the visit should look like a history, gathering the information around the prenatal course, around the birth history, what happened in the NICU, and developmental milestones. When did they start doing this skill? What are they still working on right now? A detailed neurologic exam, and the developmental testing should help to confirm the history that you're already getting, because we also know children aren't expected to perform at their best, especially in a quick office visit. Next slide. And so what testing might you encounter? Well, this is just an example a little bit about what we use clinically in our program. We use a screening assessment that can be done from 0 to 3 years, where we look at all these big 3 areas of development. They're big muscle skills, little muscle skills, and then their language skills. And we can do cognitive screening tests that can be done a lot faster, that isn't a full IQ testing. And then we work with schools and other ones too to do these more big comprehensive testings. And also for infants, you can sometimes see that there will be specialized exams that are done for infants that are getting more and more used to help for later prediction of things like cerebral palsy and developmental outcomes. Next slide. So there's major categories of the ways in which different clinics will use. So I'm not going to spend a whole ton of time on this, but this is just an idea of the breadth of the different alphabet soup of different tests and things that you all may encounter. So there's screening for development, which just determines whether or not there's a concern. There's direct assessment of movement skills. So there's like the Bailey scales of infant development, AIM. So all of these different acronyms are ways to assess movement-related skills. There's language-based assessments. There's cognitive assessments, including things like IQ testing, verbal comprehension skills, which is a little different from language, and we don't need to get into that nuance. But and like processing speed. And sometimes, next slide, it goes into attention, memory, learning, executive function. And you can see that these different assessments can only be used at certain times, and they align better with what we expect about child development. You can really do comprehensive attention-based assessments 5 and older, some that can be brought down a little bit younger, memory tests, executive function tests. Each test has its own range of what it's validated for and how specific it can be. So there's a whole lot out there. Next slide. And there never really is a one size fits all. And so we also know that academic progress, child behavior, daily function are all other things that can be assessed through different ages. Next slide. And at the end of the day, well, what can we provide the families? So when we're looking at a developmental assessment, I like to provide what's called a developmental profile, meaning that in all these different areas of development, your movement related development, your cognitive problem solving development, your behavioral assessments, when I can actually describe and quantify where someone's at in their development, we need to think about all different areas. And then we can take that profile to give a clinical diagnosis. So this describes somebody who has a significant delay in the speed in which they're developing, which is a diagnosis of global developmental delay. Next slide. And this shows somebody who has a primary language-based disorder, where their language is most affected, and it's impacting their adaptive skills, their self-help skills, and some of their social skills. Because if you have a language impairment, it will impact your social abilities. But we can see that we can, through this descriptive pattern of development, try to understand what is the core difficulty. So here was a core difficulty of language, where you had your nonverbal problem solving was not affected. Next slide. This is where we can describe, well, there's a difference or dissociation between your receptive or understanding of language and your expression of language. And that's where we'd want to understand, is it because you have trouble articulating or actually forming words to communicate? Or is it because you have trouble understanding how to create a concept of a word? Next slide. And there's also other atypical patterns, such as kind of what we sometimes see with autism, where there is a difference in the way the brain is processing information, where they have very strong vision problem-solving skills, but a lot of difficulty with the language-based communication. Next slide. And then for ideas like cerebral palsy, where it's a primary motor-based diagnosis that does not, by definition, have to have language impairment, or nonverbal problem solving impairment, but we know that there's often some crossover there too. So this is how we can say these are the specific details and how we can put it together for a description of a diagnosis. Next slide. But we also know that multiple data points are needed. We can't make all of our impressions based on a one-time point. Now, there's a little nuance here because talking through with families, getting that history does give us some additional information. So being able to talk through kind of, well, what was life like over the last year, the last 5 years? That gives a little bit of those multiple time points. And we can really understand, based on having these conversations, understanding what life and how life has gone over time to help with that next step of like, okay, well, why has this been happening and what can be offered to understand the why question? Next slide. Okay. And so, okay, now I've described a little bit of probably a very clear as mud description of kind of all of these different components that go into a follow-up visit. But at the end of the day, we know that often families have expressed and experienced being told your child will have a good outcome with these factors, or your child will have a bad outcome or a poor outcome. And I wanted to bring a little bit of context here for how I view those statements, which I don't think should be made. But I wondered if I could see what you all would kind of consider or say, well, what would you as families consider a bad or poor outcome? Because this is what the literature, the research that a lot of people pull on and use as kind of how they describe, especially in the NICU, for helping to predict the future. They use these terms good, bad, or poor. And or do you disagree that that should ever be used as a descriptive outcome? So I wanted to see what you all would think. And this is anonymous because it will be very different for each individual.
So feel free to use the Medi again. You can scan here. And thank you.
Yeah. And I know this is a loaded question because I'm talking to a group that I 100% agree with, is that in general, I think that I try to teach in my practice through all trainees and learners that we should never, as physicians or clinicians, describe a future or outcome as poor or bad because those are value judgments that we should never make. It is incumbent and a necessary part, I feel, of appropriate care that we should describe what life could look like with understanding what level of certainty we have for it, but also understanding when there is uncertainty, but being very specific for what life could look like and allowing families to take that information and apply it to their own values and judgments to be then determine if they feel that is an appropriate, acceptable potential outcome or not. Because two extremely loving families presented with the same exact information can make the opposite decisions. And not the best description. And that's what I'm saying. I 100% agree with that. And I think the efforts that Hope for HIE has been making to make sure that there is family inclusion in these big picture studies and how to derive family focused research is necessary to help move the field forward to make sure that these categories of good versus bad outcome of like this dichotomy is just not appropriate. Next slide. So in the literature, it's gotten better over the last 5 to 10 years, but a lot of what people are using and describing actually classically been into good or bad. So press next slide. So it's often been this binary system, good versus poor. And a lot of that was just the nature of statistical grouping for how they looked at these populations. Say, okay, this percentage had good, this percentage had poor. Next slide. Because they often use this idea of severe neurologic impairment as one of the major categories as poor outcome. And the way that's been defined in a lot of these major studies is that one subscale of a comprehensive developmental assessment being 2 standard deviations below the mean, or 2 of 5 being just below average, deafness, blindness, and non-ambulatory cerebral palsy are all clustered as a poor outcome. So that's just, in my mind, not an appropriate way to approach this because that's not only is that a huge wide range of comparisons between people, each individual family may have the same outcome for a child and view it very differently. And so that's why descriptions of what life could look like within the range of knowing that we don't know everything is the best way I think we should be talking about this and really focusing on what matters to families too, as opposed to what we think would be categorized in these good versus bad. Next slide. So this is where one of the things comes in too. What you'll see in a clinic is often going to be very different from what you'll see in a research study. Because the more you get into heavy research-based studies and being involved in the long-term follow-ups with psychologists, neuropsychologists, these big batteries of tests. That's not what the majority of individuals will experience in an everyday basis because it's a very different approach. So in my clinical mind, I think that we need to merge with our research to find ways to gather the most accurate information and also be able to do the best tests in our time limited and ability to see all of the individuals that need these assessments. Not everybody can get the 8 hours of neuropsychology testing, and not everybody needs that, in my opinion. But so it's a little bit different for how we approach things in a clinic as opposed to a research-based study. So there will always be differences between what you may experience going to the regular medical doctors versus what you'll see presented in research or things too, because it's a different approach to how assessments are done. Next slide. And taking all of this back, I really want us to think about how we can build a consistent support system for patients and their families. So the way we've built our program is that we're really thinking not siloed, just like everything else. Everything runs together. We want to be able to provide fetal and prenatal support with appropriate maternal care and fetal care. To be able to do prenatal diagnostics for what is necessary. We need to have comprehensive, high quality team-based neonatal intensive care, being able to do the best prognostication and support we can. And we need to tie that into long-term follow-up. And each of these are sometimes siloed for many individuals without a clear bridge. And one of my biggest goals, at least within our institution, is making this a consistent continuum as opposed to intermittent touch points. Next slide. So thank you. I know that that was a whole lot of information, but now I really wanted to be able to answer and talk about any specific questions or things for how I can provide either clarity or talk about some of these things more.
Thank you so much, Stephen. Thank you for all the information and for being here with us. I know we had one question come through on the Zoom room. So do you have a microphone with you? Or no, we're down a microphone. Okay, hold on one second.
No problem.
Okay, this is from Bill. He says, hi, thank you for making me consider symptoms on an individual basis as opposed to a disorder, quote, label, unquote. One of your slides on brain development indicates many functions are present by age 6. Appreciate there is only early experimental evidence for stem cells for brain regeneration, but theoretically, would there be any benefit in considering stem cells after age 6?
Mm-hmm. Yeah. So I think you've hit on a very big topic that has been ongoing for the past 20 to 30 years. I, among with many, many, many others, have been very hopeful with the idea of stem cells and regenerative therapy, but unfortunately, we haven't really seen, even in early onset with injury and things too, even earlier onset, significant changes in long-term outcomes. But to specifically answer your point about older ages, I would say that theoretically, because just as you mentioned, a lot of it is still even based on animal models because human-based research hasn't shown any of those long-term consistent outcomes, is that the further you are away from a sudden either like injury, for lack of a better term, or the later on in development during these stages, the less effective it's expected to be. I think the one kind of outcome study that has been used through a large review of all stem cells, specifically in the setting of cerebral palsy, showed that there was a potential minimal effect in just one population. One, if the stem cells were given under the age of 5, and 2, they already had very, very mild motor impairment. So that there's a lot of people who argue both sides of the coin to say that that little bit of one, were those the children who, based on their level of symptoms, would have with standard of care shown that little bit of improvement regardless of the stem cell or not, versus others say, hey, maybe this is something we need to focus on to then try to fine tune some of these interventions more for the right person. So I would say that yes, in general, the most preliminary evidence say the earlier, the more likely there is to be an improved outcome. But even in those settings, there haven't been great, it hasn't met the promise that we were all hoping for.
Any other questions in the room? Let's see. There's one in the room, and then we'll move to our Zoom room next. Thanks.
Is there a standard protocol for additional imaging or testing when symptoms are not matching original diagnosis?
Mhm. Yeah. So I can answer that a few ways. I would say that if, in my mind, this is where the clinical judgment comes in, where I think that if things seem to be declining or getting worse. So there's a big difference between, hey, we're consistently having bigger gaps between typical peers and the child. So let me use for an example. So a child with mild intellectual disability can often be in a regular classroom with extended reports in early elementary, extended supports in early elementary with pull-out instruction for their core subjects. Over time, they will require more and more special education services, more time in a self-contained classroom to help really focus on those skills because that gap is wider. That is not technically a regression or decline. That would be that's how we expect things to change over time with additional needs as additional demands based on age or place. But to answer the other question too, what if it just doesn't make sense? And I think that that's kind of my answer is that, hey, this doesn't quite make sense with all the information you've presented to me, with what we expect based on the history you described to me, and then never assuming an initial diagnosis is the only thing, because we know people can have more than one thing too. So I would say that if there is a true loss of skills, would be a time to update imaging and thinking about other things and really based on the individual. So that was a very non-specific answer because there isn't a good one-size-fit-all protocol aside from, hey, something is going on that just doesn't make sense. And that's really where I partner with families to say, hey, let's think about this. This is what I would be looking for. This is what it would potentially show, and those types of conversations. I hope
Okay.
that answered as non-specific as I could.
Kimberly, do you want to take the question then in the Zoom room? And then we have a few more hands in the room as well. Stephen, I know we're already running over, so we'll do like two more, the Zoom room, and then two more questions in the room, and then we'll end the session. Thanks so
Sorry
much.
about that. Sorry, I know I promised to cut it back more, but I didn't cut it back as much as I thought.
Oh, you're okay. As long as you have the time, I know you're on service this
Yeah,
weekend.
I'm okay.
I just want to say quickly, Bill, who did have the stem cell question, did say thank you for your clear answer. Disappointing, although it may be. And then we have a question from Lindsay. We are taking our child for a neuropsychological, not neurodevelopmental assessment. Do you think they would use some of the assessment and test types mentioned in your slides?
Yes. So this is where I used a combination of things that neuropsychologists tend to do, some neurodevelopmentalists do, general child psychologists use. So I would say that when we think about cognitive assessments, neurodevelopmental, so MDs or DOs, medical doctors, tend to do more brief screening and clinical conversation exam-based assessments. It's like developmental pediatricians, neurodevelopment, and kind of those specialties. They tend to be less intensive than psychology-based evaluations. Psychology-based evaluations, there's school psychology or pediatric psychology or child psychology, and then there's neuropsychology. So there's a little bit of nuance between the background and training of the different psychologists where they focus on different things. But in general, when you're doing a comprehensive psychology-based evaluation, they're doing a lot more of what they call a battery of tests than a clinical medical visit. And often, depending on the child's age, that evaluation can be 4 to 8 hours, sometimes split over multiple days, similar to school-based psychoeducational testing. So, yes, you are likely to see some of or similar tests when you're looking at neuropsychology, because it's going to be a lot more formal, standardized evaluations where, and of course, I'm biased, but I like my medical model too, where we take that as just a piece of information and apply clinical judgment to some of these diagnoses.
Hi. I'm in Canada and they do those psychological tests like all in one day. So they're like, my daughter went and they're like, this is how we're assessing her after like 10 hours of testing, right? So I thought it was interesting you were talking about like doing it over multiple days, multiple weeks, multiple months, right? Would even be better. Is that something you're pushing like to have done for all hospitals and assessments?
So I would say that so this is where there's a big difference in systems. There's the Canada has a wonderful neonatal follow-up system kind of nationwide, and a lot of them are protocolized that have that kind of formal kind of this is your battery of tests at this age. I would say it's just different. It's a different approach. My assessments are 1 to 2 hours tops at the different time points. And I really, based on how we practice and what resources we have available, I partner a lot more with schools. It's not that I'm offloading the school-based paperwork, but at the end of the day, for a child to get school-based intervention supports, they need the school-based assessment anyway. So then I ask for that additional third opinion or the neuropsychology or the other external medical piece if it's not aligning with clinical judgment and making sure that we're meeting towards that progression of goals along with family. So I would say I think that's too much for a child at one day, but it does give you a better, more fine, detailed, comprehensive picture. So I would say that it all depends on the context. That's kind of more the heavy research end where you get a lot of big picture outcome. I'm not sure how much that fine tune actually helps on an everyday basis.
Questions in the room? Oh, okay, sorry. One more question in the room. Thank you.
For this testing, the Bailey's or the Capote scale, what do you think is kind of the best for like an HIE kid to sort of track their progress over time?
So I would say that a Bailey is so there's I'm going to take a step back. This is a big difference between medical approach for how things were developed versus a research-based psychology development approach. So the Bailey Scales for Infant Development is a much larger, comprehensive, a little bit more of a cumbersome assessment that provides more fine, detailed assessment, but it can also take a lot longer to perform. Depending on who performs it, it can be very limited and not able to be adapted, especially if a child has motor impairments, where things like the Capote scales have a very good correlation to what a Bailey's done, but can be performed in 20 minutes. So I would say they're very different for how it's approached. I wouldn't say one's necessarily better than the other. I personally do not use the Bailey in my clinic because I find that to help provide the info I need to provide the family, it's doing the more brief screener medical-based approach than taking 3 hours to tell you that a 12-month-old is doing milestones of a 9-month-old isn't quite necessary for families. So they're different. I wish I had I have my own clinical opinion for the resources I have, but I don't think one for an outcome for families. And I think that's come out in research too, that kind of the end scores compared to brief screening that gives a comprehensive recommendation for therapies, as opposed to these larger institution things, don't necessarily add a whole ton. But a lot of times Bailey's required in research networks for outcome data, and that's why people tend to use it.
Well, Stephen, thank you so much for being here. I know that you took time out of your weekend and while on call too. So we really appreciate it. As I mentioned earlier from the previous sessions, all of the slides will be shared and these sessions are recorded as well. So they'll be available afterwards. Thank you, Stephen.
Of course. Thank you all so much.